Hello and welcome. Thank you for allowing me to present the results of our study, bladder infusion versus standard catheter removal for trial avoid, a systematic review and meta-analysis. There are no affiliations to disclose, and this project was self-funded. The aim of this study was to compare the efficacy and time to discharge of two methods of trial avoid, bladder infusion versus standard catheter removal. Our hypothesis is that bladder infusion prior to trial avoid will lead to improved time to discharge. Electronic searches for randomized controlled trials comparing bladder infusion versus standard catheter removal were performed using multiple electronic databases from dates of inception to June 2020. Participants underwent trial avoid after acute urinary retention episodes or post-operatively after intraoperative indwelling catheter placement. Quality assessment and meta-analyses were performed with odds ratio and mean time difference used as the outcome measures. Eight studies comprising 977 patients were included in the final analysis. Pooled meta-analysis demonstrated that successful trial avoid was significantly higher in the bladder infusion group compared to standard trial avoid with an odds ratio of 2.41, without significant heterogeneity. There was no significant difference in complication rates between the two groups. As you can see here on the Forrest plot graph, the lowest diamond indicates the pooled analysis results, which shows a result in favor of the bladder infusion group, and the result statistically significant, as you can see, as the diamond does not cross the midline. The bladder infusion group had a significantly shorter time to decision in compared to standard trial avoid, with a weighted mean difference of 149 minutes, and also a shorter time to discharge of approximately 90 minutes, weighted mean difference. Shown here is the Forrest plot graph, with the top diamond representing the weighted mean difference in favor of the bladder infusion group for time to reach decision, and similarly the result for time to discharge was in favor of the bladder infusion group, and this is represented by the bottom diamond. The current study has several limitations. Firstly, the relatively small sample size of included studies limits certainty in reaching definitive conclusions, whilst the magnitude of effect is of uncertain significance without robust and dedicated cost-effective analysis. Secondly, individualized patient data were not available for each study, so adjustment for heterogeneity in factors known to contribute to trial avoid success was not possible. These important factors may include factors related to patient selection, such as the reason for IDC insertion, whether that be for acute or chronic urinary retention, insertion intraoperatively, but other factors include the duration or complexity of surgery and pre-existing medical issues such as detrusor failure, and also medications such as diuretics and alpha blockers. Fortunately, the subgroup analysis according to specialty, and in this study that included urology, gynecology, and combination groups, was possible, which allowed for the grouping of similar patient demographics and definitions of trial avoid success and failure. While the significance and explanation for heterogeneity in meta-analysis is complex, the more homogeneous results according to specialty and gender may suggest a greater benefit in women post-operatively, compared to men or following urinary retention. In conclusion, our pooled analysis of the current literature demonstrates that the bladder infusion technique of trial avoid may be associated with significantly increased likelihood of successful trial avoid, and subsequently reduced times to discharge in post-operative patients and those with acute urinary retention. These findings require confirmation in large phase 3 trials specific for the clinical situation, with appropriate cost-effectiveness analysis to definitively demonstrate an expected benefit to both individual patients and the broader health system. Thank you for your time.